Good morning, Ed. We are here in this cold and frosty morning to do a little bit of a fireside chat, talking about all things health scrutiny and really trying to help scrutineers understand what the changes to legislation mean in practice. I'm Camilla. I'm the newest member of the CFGS team and the Director of Practice, and all of you will know Ed.
Hello, everybody. I'm Ed Hammond. I'm the Deputy Chief Executive of the Centre for Governance Scrutiny and have been at CFGS for 15 years now. So,
Goodness, long old time, Ed. Let's dive straight into it. So, in a nutshell, what is changing with health scrutiny?
well, the big thing that's changing, and this change is happening on the 31st of January. So, at the time of recording, it's the 19th, and so we're only a few days away. Is the removal of the power that is currently held by health overview and scrutiny committees to refer matters of concern relating to changes in health and care in a local area to the Secretary of State. So at the moment, if you're if you're a health overview and scrutiny committee, or indeed a joint health overview and scrutiny committee, if the NHS locally, if NHS commissioners are planning major service changes, and you as a health scrutiny members, or indeed the officers who support them, consider that those changes haven't been consulted on particularly effectively, or indeed that those changes aren't in the interests of the health system in the local area more generally, there's a power to submit a formal referral on those matters to the Secretary of State. And on the basis of that referral, the Secretary of State can intervene in the issue. And usually what will happen is that the Secretary of State will send on the matters to the independent reconfiguration panel, who will carry out an investigation and make a judgment about what should happen next. That power that's existed for health scrutiny since I think 2003 is being abolished. It's being replaced by a broader power that the Secretary of State will hold in their own right to intervene. So there will be a right for local areas to request, for anybody in a local area, in fact, to request that the Secretary of State intervenes and uses their what are called call-in powers to intervene where any proposal is made on changes to local health services. So they don't have to be substantial or major proposals for change. It can be any proposal for change. But the Secretary of State can act without necessarily having received such a request from a local area. So while that request can come in from any local person, the Secretary of State can also act off their own bat. So it's an enormously broad power for the Secretary of State to exercise. And there's guidance that's been issued by government in the last few days, statutory guidance for the Secretary of State and for other partners in how those powers should be exercised, which make very clear that the Secretary of State will only intervene where local attempts to resolve the issue have been exhausted. So where there's a disagreement or dispute at local level about the nature of the change, what the impact's going to be, its seriousness, whether it should go ahead or not. Now, exhaustion of those arrangements probably looks like some form of local consultation. It looks like engagement with and discussion with between NHS commissioners and HOSCs. It looks like, well, I mean, it could be anything really. I think that it's a matter on which the Department of Health will make a case-by-case judgment, but only then will the Secretary of State sort of go in to firstly look at the issue and see, does this justify the use of my call-in powers? And then when those call-in powers the Secretary of State considers are justified to be used, carrying out a more formal investigation, often in partnership with the IRP, and consulting formally local partners on it. And scrutiny will be one of the consultees on those issues.
And that's an important point, isn't it, really, that
Exactly,
scrutiny is still a consultee. And really,
yeah.
in lots of ways, I think for those of us who've done a referral before, it's quite a frustrating process. And this, widens it out and potentially involves local people. So should make it more straightforward from the kind of complicated and frustrating process that is there at the moment.
Well, yes and no. I think certainly in terms of from that perspective, you could look at it and say, well, this removes what otherwise would be a barrier for local people, because previously, it was the HOSC that had to make the referral. So if you're a local campaigner or an advocacy group or a patient, previously, in order to to try and trigger the Secretary of State response, you would have to go and kind of lobby your local HOSC and say, look,
Yeah.
I think that this power should be used. Now you can submit a form, or from the 31st of January, you'll be able to submit a form, and that will go straight to the Secretary of State, and it will, trigger a consideration of the process. The problem is that this issue about the power only being used in cases where local resolution's been attempts have been exhausted,
Yeah.
and you can see situations where local people write in and say, oh, there's this serious issue, and the Secretary of State responds saying, well, I think there are other things that could be done locally to try and resolve this issue, and then there's the frustration of being knocked back. I do
Yes.
still think that HOSCs can play a central role in coordinating that and convening that conversation about resolution and saying, what are we going to do collectively to try and resolve this? That involves patient groups, it involves clinicians, it involves commissioners and providers, and to say, we've got this disagreement here. What are we going to do to try and resolve it? I think that's one of the reasons why and in the most recent version of the guidance, government has highlighted the importance of local memoranda of understanding or protocols between commissioners and HOSCs specifically, so that it's easier to make this judgment about what are those local resolution mechanisms going to look like. Because I think it'll be very difficult for DH civil servants to, if they get a request or if the Secretary of State is minded off their own bat to look at something, how do you get that sense locally of what's going on? You've got
Absolutely.
several dozen ICSs across the country. Over the course of those ICSs, you've got possibly at any one time, uh, you know, probably, maybe over 100 live sort of reconfigurations at some point, or
Absolutely.
major reconfigurations, not to mention the other kinds of proposals which aren't major or substantial in nature, but which still may be subjected to the call-in power. There's a
Yeah.
lot there.
There's a lot to unpack there. Just
Yeah,
pulling back a second, I think because there is a danger of sort of getting lost in some of the detail of this.
there is.
I mean, a lot of us have been working in this area for some time, but for those who are new to the health scrutiny arena, or really are still struggling to get their heads around what changes the Act brought in, could we just spend a bit of time? You mentioned ICSs there are ICBs, there are ICPs. Could you just walk us through what those structures mean at a local level, please?
Yes, no, and it is complex, and we've had over the course of the last decade and a bit a couple of really major structural changes to the NHS in England, which have brought in a complex array of new abbreviations and acronyms. And even in the intervening time, there have been other abbreviations and acronyms that have come in as well, that have come and gone in the interim, that
Yes.
we need to unpack. So a lot of people will probably be familiar with the existence of what were called clinical commissioning groups, and at a local level, every sort of local authority area, by and large, was coterminous, so it shared its boundaries with a clinical commissioning group, and that boundary sharing, which sort of coterminosity, as it was jargonistically described, was generally brought about in the sort of mid noughties, when
Yeah.
the primary care trusts, as they currently
Moved into, yes.
reformed to sort of, so they shared the same boundaries as upper tier or unitary councils. And so CCGs were the sort of primary body that had responsibility for commissioning health services from providers. So you have this distinction between NHS commissioners and NHS providers. So providers are acute trusts, community health trusts. They're the other bodies that run hospitals, run certain community services. They run mental health
Mental
services.
health. Yeah.
These kinds of things.
Yeah.
They're the trusts whose logos are on the signboards outside hospitals, that kind of thing. So they're the bodies who are delivering, who are providers, but they're commissioned by CCGs. Now, what the NHS in England sort of came to realise in, I suppose, getting on for sort of about 6-7 years ago, was having commissioning decisions made by CCGs at that local level didn't take account of wider opportunities for more strategic change.
Yeah.
The geographical footprint of individual CCGs is comparatively small when you think about how health services are divided across boundaries. So if you think about, I live in London. Each London borough has a population of 350, 400,000, but a lot of people in London boroughs will use health services from out of borough.
Of
So
course.
I've got two
It might be
local
closer
hospitals.
to them. If
Yeah,
you're on the boundary between two, it might be your local
they are.
hospital, and
Yeah,
actually you have no real connection with there's a boundary there. I will go this way even though it's longer.
yes, exactly. Yeah. So I think in terms of commissioning those more complex, specialist, acute services, um, the NHS England sort of and government developed what were called sustainability and transformation plans, STPs, back in 2016, 2017, with a much bigger geographical footprint, with the idea being, how are we going to think about think things at a greater scale in order to make bigger, more strategic, more transformative decisions about the future of the health
Absolutely.
service. Now, that started out as being quite informal, and it was, STPs were sustainability transformation plans, and then they became sustainability and transformation partnerships. And over the course of the intervening years, there's been this gradual formalization of that bigger geographical space, to the point where back in 2020, 2021, government said we are going to place these bodies on a statutory footing now, and they're going to be called integrated care systems. So I just wanted to get people to get a sense about where this has come from. So this is not something that's brand new. This is something that's been percolating through the system, and it's very unusual in terms of NHS reforms, in the sense that it's been quite bottom up. It's been driven by NHS, clinicians and managers at a sort of local level within NHS England as well, defined by what the sense is that local need is in terms of service redesign. So this isn't something where government, perhaps uniquely, is coming in and saying we're just going to do a reorganisation for the sake of it. And it's sort of developed from a sense that the 2013 reforms didn't really work in the way that people expected or wanted to do. So that's where we are. That's where we are now. So what we have is we have these 47, 48. I'm not quite sure exactly how many there
Well
are.
remembered.
I don't know.
Almost.
That
We will
probably
check
isn't
that.
correct. We'll check that. We will check that. A number of integrated care systems across England, covering, some of them a very, very large geographical footprint. So if you look up right very north of England, you've got one for Northumberland and part of Cumbria. So covering an enormous,
huge,
and down in the southwest as well. There are a couple that are really, really big. And they are those sort of integrated care systems are responsible for bringing together commissioning on health and care. So it's a really, really important point to make about the way that this works, is that this is reform to the health and care system. People will have heard a lot about the integration agenda, integration of health and adult social care, and this is another step down that road. But what we're talking about in terms of the health scrutiny reforms is specifically reforms to scrutiny of health services, NHS. This is the thing. Institutional changes being made by the NHS, and that's where this kind of slight kind of potential confusion kicks in, because obviously you've got councils delivering some certain care, social care services, which obviously, and where councils propose major changes to health services, that their care services, they aren't subject to this form of scrutiny. So that's an important distinction to make. So you've got this sort of position where you've got these sort of bodies, these commissioning bodies called integrated care systems. They themselves are comprised of kind of two separate things. There is a statutory integrated care board, which is the commissioning body that sort of makes the formal decisions. Then you've got something called the integrated care partnership, which is a kind of joint committee type structure, which brings together local authorities, health partners, and others, depending on local determination. So there are some bodies that have to sit on that integrated partnership, but there's a degree of discretion, I think, in terms of who else sits on it. And the idea is that the ICP informs what the ICB's decision making is. And the ICP is sort of like a health and wellbeing board. So people will be familiar with the existence of these,
Absolutely,
your health and wellbeing boards at that bigger, what we call system level.
and as a board of decision makers, not a decision making board.
Yes, exactly. Yes, really, really important. Important. It might seem like sort of technical
semantics,
distinction,
but yes,
but it's really important, because that's right. The board itself isn't the partnership itself
doesn't
is
make
not
decisions.
is not a decision making body, but the people on it will themselves be decision makers. The idea is to draw together people with that individual authority to coordinate decision making on health and care across an area. So that's the logic that underpins the wider change. It's about more strategic decision making across that wider level, and that those changes actually came in July 2022. So we are a good 18 months on from the introduction of those more fundamental changes.
And so coming back to health scrutiny, I think that's a
Yeah.
really helpful context. So we've said the major change at the moment for health scrutiny is the loss of this referral power. And just for
Yeah.
clarification, because I know there's been a lot of this has happened quite quickly, it is the 31st of January. So any health proposals or at that stage that have not been sent to the Secretary of State for a referral are now considered under the new powers. That's absolutely right, isn't it?
So yeah, the situation is that if you send in a referral to the Secretary of State before the 31st,
Of
it will
January.
continue before
Yeah.
the 31st of January. It will
10, 11
continue to,
days.
yeah, yeah. It will continue to be dealt with under the old framework. So a government has introduced particular saving provisions in the regulations so that those referrals, live referrals and referrals that people may make over the course of the next 11 days or whatever it is, will be dealt with under the old system. From the 31st onwards, the power will be removed. So that's it, because irrespective, to be really clear, of whether there is a consultation ongoing at the moment, the only criterion is there a live referral? If there is a live referral now, or if there is going to be a referral sent in between now and up to and including the 30th, it will be dealt with as a referral under the 2013 powers. If that doesn't happen, even if there is a live ongoing consultation, even if you're thinking about, using a
or
referral
have
power,
had some of those conversations
yeah,
locally, actually, if it's not in by the
if it's not in by
31st,
the 31st,
that's not a referral.
that's not a referral and it can't be dealt with
Yeah.
under those arrangements. So I know that some colleagues may be thinking right now, God, is there live stuff out there at the moment where we might want to kind of to throw something in
Get
as a
it in
referral to Secretary of
quickly.
State. If you want to do that, and obviously you've got to take a considered judgment about whether that's the right thing to do, and there's got to be a justification for it. But if that's in prospect, and if you've been talking about that hitherto, then do take advantage of the opportunity to do it before the 31st.
Fantastic. I think that's really clear. We've spelt that out well. I'd
Yeah.
just like to go through some of the other aspects that health scrutineers will be familiar with. So, substantial variation. Now, I know for, 15 or so years, we've been talking about what is a substantial variation. There's no guidance for what a substantial variation means. Does this still matter at all under the new arrangements?
Well, it matters a bit because where a change is substantial, then the commissioner has an obligation to notify it to the Secretary of State now. So there's an obligation on commissioners to specifically notify the Secretary of State when a substantial
Yep.
variation is happening. So, and also obviously the existing arrangements that exist with regard to substantial variations continue. So there still must be a statutory consultation. That process must involve health scrutiny. So that obligation, the statutory consultation process, and the formal obligation to involve scrutiny in that process does continue. So there's something important to consider there, just because, and also where the even though the Secretary of State's powers to intervene go beyond just substantial things, and they can
Yeah.
intervene on any proposal, whether a proposal is substantial or not is one of the criteria to be used in order to make the
Okay.
judgment of whether to intervene. So one can assume that means that if something is substantial, that you know
Has a bit
provides
more
a
weight
exactly
for an intervention than it might otherwise be. It
exactly
doesn't make that judgment call, but it's more
exactly
likely in those cases. So I guess it's then notifiable, and we would expect health scrutiny to continue in other tier authorities exactly the same way, then, wouldn't we? So where the health body has notified something, actually it's then up to health scrutineers to determine how they want to look at it, how they want to be part of the consultation, and how those conversations happen at a local level.
Yeah. So there are two or three things that practitioners ought to be aware of that will help them with this in the negotiation and conversation with
Mm.
local commissioners about what's happening. The first thing is the National sort of Service Change Guidance that NHS England produced back in 2018. Now that guidance was produced under the sort of previous sort of formal legal regime, and I imagine that NHS England will be updating it fairly shortly. But as it currently stands, that service change guidance has a fair bit in it about consultation, about scrutiny as well. So that's something which we have to have regard to. The second thing is the Overview and Scrutiny Committee principles, which government published as guidance back in 2022. And those are intended to inform ongoing relationships between commissioners, providers, and HOSCs in the new arrangements. So those kind of set out what I suppose the underpinning principles should be that inform the relationship and how conversations ought to happen. And the third thing is what the newly redrafted health scrutiny guidance has to say about the expectation that commissioners will engage with HOSCs early in the process. This is really important. I'm not sure if we had something quite this explicit in the previous guidance, whereby government is saying, hopefully relatively forcefully to commissioners, you've got to engage HOSCs early in the process.
I bet that wasn't in the previous guidance.
Yeah. So this is not about saying, HOSC is just another consultee and you're designing a consultation process and you're consulting them alongside your other consultees.
Yeah.
HOSCs have a stake in the design of the consultation itself. They have a stake potentially in the design of the proposal. So there is something about that earlier involvement. So again, we go back to this issue about memoranda of understanding, about protocol, about the need, I think, and there's something, again, a little bit stronger than previous words the government have used in the guidance there saying, do prepare these documents and, do use these documents actively. And I would strongly encourage practitioners now to go to their ICSs and to talk to neighbouring HOSCs as well, and to say, we probably need something in place that will govern and manage these processes, because it will make things much easier than if you're having to reinvent the wheel every time. That also goes for joint scrutiny work as well, because we know that in the new framework, because ICSs cover that wide geographical footprint, as an organisation, expectation is that will mean that there will be more more proposals coming through that will require joint scrutiny work.
The JOSCs.
Hence, the need for those wider protocols, I think, is more pressing than it otherwise would be.
Lovely. Just coming back to some of the process, I cringed a little bit internally when I saw it, because councils understand call-in to be something very, very specific, but also we've got this power of call-in, which is related but different. And I just think it's worth spending a couple of minutes on, how the power of call-in will work in relation to health scrutiny and the Secretary of State.
It's one of these slightly unfortunate kind of things where we've got sort of the same word or abbreviation being used to describe very different things. IRP is another one, which is the Independent Reconfiguration Panel, but obviously for those of us in local government, it's also the Independent Remuneration Panel. Call-in is not anything to do with the scrutiny sort of call-in powers that operate at local level. This is something which is the power held by the Secretary of State to, when there is a live proposal out there for changes to health and care services being put forward by an NHS commissioner, the Secretary of State can given their awareness of that thing, investigate whether they should intervene in that issue, and then can intervene. And the power to intervene is very broadly expressed. So, as I said, obviously local people can request that intervention happens, and that includes health overview scrutiny committees. But the Secretary of State can act off their own bat as well, so they don't have to get a request in order to be able to trigger that calling. When the Secretary of State considers that an issue should be, intervene, and the Secretary of State will need to undertake a process to gather evidence and information to inform that, then they will kind of formally invite people, including scrutiny, to submit representations on what they should actually do. So I'm calling this in, I'm issuing an instruction to the commissioner on what to do with this thing at the moment. So either that could be, we need to stop the process temporarily so that this process runs through, or you need to continue with the consultation in parallel with what I'm doing here, or it could be something else. Secretary of State gathers evidence. Probably it will be the IRP leading this process. We don't quite know yet. We don't know exactly what the division of responsibilities is going to be. Judging by previous instances where, under the referral regime, my gut feeling is that it will be the IRP making most of the running on this. But we'll see. We'll see. And there's that sort of process by which people can make representations, and then the Secretary of State makes a decision, and that decision can be things continue as originally planned, or we make a change to the proposal, or the proposal gets taken off the table, or something else that
Or
might be a combination of those
we'll
things.
see, depending on the
Yeah,
specifics.
the Secretary of State issues a direction to the Commissioner. The Commissioner is under an obligation to implement that direction, and that's the process. What they say in the guidance is the Secretary of State's decision is final. I mean, in one sense, it is. Obviously, in the sense of administrative law, it is subject to judicial review, as
Of
any
course,
administrative decision is. But
absolutely.
we can,
For
and that
scrutiny purposes,
for
I think
scrutiny
that,
purposes,
yeah.
that's the end of that is the end of the story. But it will be interesting to, and this is my reflection. If you think about particularly contentious or controversial
Mm,
reconfigurations that have particular local salience, and I'm thinking of one in my local area. About 10 years ago, there was a proposal to close down and or downgrade an A&E, enormous local campaign. Probably one of the
yeah.
biggest in the country so far, about that, and the decision was reversed. Now, if you have the Secretary of State who says no, the proposal should go ahead as originally planned, would or could local campaigners JR judicially review that
Mm.
decision? I, 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 I mean,
Yeah,
yeah, I mean, because obviously we're currently in the situation where when you refer, a similar process gets undertaken. But my thinking is, the breadth of the Secretary of State's powers now, the issue about where they choose how and when to intervene and not to intervene, it gives them very, very broad discretion. And the thing about
absolutely.
discretion is that it opens up space for challenge.
Challenge. Yeah,
So,
exactly,
so, so,
exactly
so
that.
this is, yeah.
That I think that will be very, very interesting over the coming kind of months and years to see actually how this works in practice, and that of course is the challenge. I guess a really broad question before we start wrapping up, but it's just whether you anticipate that this is going to change the nature of health scrutiny significantly.
I think it will up to a point. I mean, I think one thing we've got to remember is that the wider powers around health scrutiny are staying exactly the same. So people have the right to get NHS partners into the room to ask them questions. They've got the right to get hold of information from the NHS. They've got the right to get the NHS to respond to recommendations. And that now includes ICSs. So ICSs are one of the partners that have a responsibility to engage with scrutiny in that way. So those powers very much stay the same. And DHSC have been very, 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 very clear and very keen to be very explicit that this is going to, have not going to change that aspect of things. I think in a more informal way, I think it will shift the
Mm,
relationship though with local commissioners. There was something very powerful about the referral power being there in your back pocket.
yeah,
And knowing that was there kind of brings and brought commissioners and providers to the table. And my worry would be that the perception that this has been weakened, the perception that health overview and scrutiny powers have been weakened, because they fundamentally they have, might lead commissioners and providers to be more perfunctory than they already are, because I know that in some instances there
in
are
some
already
areas they,
problems, yeah, and
yeah,
have been in the past problems about this. When you think about the disagreements that exist over when something is substantial or not, which authorities are included, because one thing we haven't talked about is patient flows, which is a sort of technical
absolutely.
issue, which is about which people are affected by this change. Um, Having the referral power there meant that it was easier to kind of force that conversation to happen about what is this, what are you doing.
Mm,
My worry is that we will see some bumps on the road in terms of the relationship, because
yeah,
and one of the things that we've been really keen to do is to engage with NHS England to be so that we're saying to them, what is the communication that's gone out to commissioners about this change? How is this being described and talked about with commissioners? What can we do together to get the point over to commissioners? This isn't about cutting health scrutiny out of the system. This is
it's
actually about uh, this actually is about getting health scrutiny and health commissioners to work better together, because of that
absolutely.
stuff about local resolution being really, really
Which is
important.
really, really key, and
Yeah,
looking to that local resolution actually before something has got on the Secretary of State's desk. How have you had those conversations already? And that's
exactly.
very clear in the guidance, but whether or not that is well communicated, I guess, is a good question, and how local people are having, or local scrutineers with their NHS representatives are having those conversations. And again, this goes back to your point about the memorandum of understanding, and actually being really clear about different partners' role in any kind of local configuration.
Yeah, no, that's right. And I think there's a lot there about the relationship that remains unclear. And I think
Yeah.
in that context, it's really good that DH have said, have said explicitly, we are going to actively review how this is going, and we're going to update the guidance in a year.
Yeah.
So they have said, and that this is relatively unusual. This is not something which government departments usually say off their own bat, but they've said they're going to do that, and I think that's positive. So what I would say to people is have regard to that and how you're conducting this, and note down things that
Yes.
you're experiencing, because and be ready to feed them back in
Yeah,
to us and to government in due course,
absolutely.
because we have found civil servants to be open and frank in their dealings with us over the course of the last 2.5 years or so. The timing of the change and the speed with which it's been carried out since they announced they were proposing to do this in January back in October, that's been unfortunate. But I recognise this has kind of been driven by ministerial intent rather than civil service colleagues. And civil servants themselves who've been leading on this, on the implementation, have been very keen to be as open as they can, given the constraints under which they're operating, to engage with us,
Mm.
sort of as proxies for practitioners. And ideally, we would have had a broader, more open process, but we are where we are. And I have no reason to think that won't continue. So I would encourage people to think about how this is going down, to feed through to us,
Mm.
or feed directly to DH colleagues their experiences, and we can take stock in a year's time and think, what does this mean for arrangements long term?
I think that's really helpful, that point that this isn't the end of the conversation, actually keeping that conversation going. Aligned to that, and we are coming to the end now, but I just wonder if we have any sense of how residents, local campaigners, MPs, of course, because they'll have a role in things, and really all levels of councillors will find out about these changes if they're not currently engaged in that scrutiny landscape.
Yeah, as far as I'm aware, there's no national plan to conduct any kind of, and you can't imagine there would be, because it's the kind of thing that would
It's
be
quite niche.
it's quite niche. Yeah, I think it's something that will probably emerge, sort of proposal by proposal. I would probably suggest to scrutiny people conversations with local health watch in your area, probably
Yeah.
conversations with the ICS as well, as part of that kind of memorandum style conversation, to say, what, if anything, are we proposing to do to bring this to the attention of local people? I think so that there's consistency in the message going out to local people, because my worry is that you've got different organisations in play here, all
Yeah.
saying slightly different things about what these powers are, who people should approach. People can make these requests directly to the Secretary of State. My worry is that people may find out those powers exist. Will sort of
Yes.
say
Yep.
this, and we'll get knocked back, and we'll then think, I've got to deal with this kind of labyrinthine local system. What does this mean? I've got to
How do I navigate
how do I
the way
navigate through
through?
this?
Yeah.
And so I think local partners can and should come together to make sure there is something public facing which makes it clear what those links are, through Health Watch, through commissioners, through individual trusts, through potentially even, primary care networks as well,
Mm.
which there's a very, very local part of the system, GP surgeries, that kind of thing, so that there is this
And
awareness.
even public representation at scrutiny committees to bring
Absolutely.
issues to
Absolutely. Yeah.
scrutiny, to then go, actually, this has been considered on a local level, and
Yep.
potentially we're still unhappy, and therefore it's a
Uh,
referral,
uh,
maybe not in scrutiny's name, but actually from a campaigner's
uh,
perspective.
Absolutely, yeah, and there will be existing kind of standing campaign groups on a variety of issues, and patient advocacy groups as well, who will want to know about this and who will need to know about this, and where I'm fairly certain that the change won't have been telegraphed ahead of time. So there is something there and I think local health watch will be well placed to be aware of those people where they exist. Possibly there's something for PALS, patient advice and liaison service, there as well to have regard to, in terms of the wider work that it does, but that's perhaps
That's
less so.
that's a really helpful hint, Ed. Thank you. So scrutineers listening to this, so officers, members, people working in health scrutiny at the moment, hopefully this has been helpful. But actually, if local authorities want more guidance, where can they go? What else is planned? What else is happening? Where can they go to seek a bit more information on what's happening?
So we've published on our website a kind of summary of the changes, which signposts to other more detailed sort of resources. So there are sort of two new pieces of bits of regulations. So there's an amendment to the 2013 regulations. There's a whole new set of regulations on that notification procedure that I sort of told you
Yeah.
that we talked about. And then there are a slew of bits of guidance. So there's revised health scrutiny guidance, which is a revision from the last set back in 2013, 2014. There's wholly new guidance on the Secretary of State's powers. And then there's that sort of background information, the health overview and scrutiny principles. There's the service change guidance as well. All that is linked to in the sort of the guidance on our website, which
On
is
our website,
hopefully
yeah.
relatively clearly accessible. If you just navigate to the front page and write health scrutiny in there, it'll be one of the first things on the publication list as well. So in a more general sense, what we're keen to do is to discuss with partners nationally and locally what more needs to be done. I think that there is a pressing need to provide slightly more detailed guidance to people about memoranda of understanding and about transacting joint scrutiny work. I think joint scrutiny work in particular has always been a bugbear for people. It's quite resource intensive. It's complex to set up.
And navigate different political parties.
Absolutely, yeah.
How do two areas or more come together? Who resources it? There's a lot of questions around it.
Yeah, and I think if we're going to see more of that, and even if we're going to see a kind of quasi expectation from some that we're going to have set up sort of standing joint arrangements, which I'm not wholly sure about, but I kind of guess I sort of understand. I think we need clarity over how that's going to work in local areas, having clear, unambiguous, straightforward local arrangements, and also, frankly, who's going to resource it. I mean, we as an organisation have argued throughout the process that ICSs should, because health screening is part of the system, ICSs should think about the resource contribution that they can make to the operation of joint scrutiny arrangements in particular. Now, I think you have these kind of conversations and you feel like you're on a hiding to nothing, but I do think that there's a conversation locally to be had about that in the context of memoranda. So I would like us to be able to produce something that goes into that detail, that where we can talk to commissioners, talk to providers, talk to HOSCs, and talk to the national bodies about that, so that people have a framework within which they can put those local agreements in place. Otherwise, it feels like everybody's going to have to be reinventing the wheel themselves. So that for me is some of our priorities in the coming weeks and next couple of months. Beyond that, I'm quite keen that we be in a position to be able to actively support people in undertaking joint scrutiny work itself. Because if there's going to be more of it, I think there's going to be more need for support and help.
Yeah.
I would like to get a sense from practitioners about where they think these things are coming down the tracks, and if so, whether they think they'd benefit from that support, because obviously we need then to build a case to take to others about what we can do to provide that support practically in a bit more detail.
Fantastic, Ed. So first port of call, our website. Other things are planned in a nutshell, but also I think what's come through this conversation a lot is actually we don't exactly know how this is going to work in practice. I think we anticipate that actually a lot more support is needed for scrutiny practitioners working their way through things. And I think welcome that two-way conversation and continuing this conversation. I'm going to draw it to a close there and say thank you so much, Ed. Your wealth of knowledge on this is really, really valuable. I'm hoping that people listening to this have found this helpful. It's the first time we've done a discourse like this. Really interested to get some feedback on whether this has been helpful and whether this is something you'd like us to continue in the future, talking about particular issues and kind of exploring them in a little bit more depth, and just looking at that from a dialogue perspective. So thank you, Ed. It's been really helpful. Please, anyone listening to this, let us know what you think of it. Let us know how you're getting on with health scrutiny and the changes. And we look forward to speaking to you more in the coming months as this unfolds. I'm just about to, there we go.